Assalamu alaikum, everyone. My name is Ismail Abdullah. I'm a fifth-year medical student, and today I'll be doing the third and the final part of the Heme on crash course. Inshallah, in today's crash course, I'll be covering these 7 lectures. I'll try my very best to be concise, straight to point. These lectures are very, very heavy when it comes to exam content, I would say. There's a lot of high yield. Unfortunately, most of these are pathology lectures, which means that you need to be able to learn a lot of details. Okay, so I apologize for that. Inshallah, I've tried to cover these lectures in a way that are coherent and smooth so that by the end of the session, you'll be able to understand all of these lectures confidently. Tamam. So we will start with the basis of hemostasis and thrombosis. Now, just something that I did. Basically, when you see 3 asterisk marks, this means that this is very high likely to show up on your exam. Okay? So when we say hemostasis, what do we mean? So hemostasis is not homeostasis. Okay? Just keep that in your mind. They're 2 different things. So when we say hemostasis, it's basically the physiological process preventing blood loss after a vascular injury. Okay, and if you think about it, it's trying to controlling the environment of blood by keeping a balance between the things that would cause the blood to just bleed or cause the blood to clot. So procoagulant, anticoagulant forces. Now, if this balance breaks, if it becomes imbalanced, all right, you will either bleed or you would either get thrombosis. Now, this is very important. This might show up as an SAQ. This might show up as an MCQ. This might even show up in OSPE. You never know. Okay, so it's very important to keep in mind. Hemostasis has 3 phases. Okay, so a vascular injury happens. First thing that's going to happen is vasoconstriction. And this is very important for you to remember. Vasoconstriction, then we are going to have primary hemostasis, and then we're going to have secondary hemostasis. Okay, usually, sometimes in some books, even in some lectures, even in some questions, they refer to primary hemostasis as platelet plug, and some are going to refer to secondary hemostasis as coagulation cascade because it's all about just clotting the blood. Okay, done. So before I dig into these, you guys want to understand some things that I'm going to say that might sound Chinese to you. All right. So this picture is super important. It will show up in every medical year you're going to be in. Okay. And I think this is the basics that we're going to be building on in our hemostasis, even in our hemostatic disorders. Okay. So first of all, this is your endothelium. And on the endothelium, we have the von Willebrand factor. The von Willebrand factor binds to the JP1B protein on the platelet, okay, so that just the platelet can bind to the endothelial wall. So adhesion, all right? Now, for aggregation purposes, platelets between each other will have what we call the GP2B3A complex, this blue thing right here. And basically, they're going to bind with another, another platelets. It's very important to know this. So for aggregation, it's going to be GP2B3A. For adhesion, it's going to be GP1B. All right. Now, so if the issue is that the platelets cannot aggregate, meaning they cannot clot, so if the patient might present to you with prolonged bleeding time, this is what we refer to as Glanzmann thrombasthenia. We're going to talk about it. And then you also have, if the platelets cannot, bind to the von Willebrand factor and cannot adhere, I don't know if adhere is a real word. Okay, that's called Bernard-Soulier syndrome. Okay. Now, you want to keep in mind that the von Willebrand factor is the double sword here, because if it's not there, nothing's going to happen. No aggregation is going to happen. No adhesion is going to happen. And basically, the patient will just keep bleeding. So it's going to affect both primary and secondary hemostasis. It's very important potential MCQ. Okay. So primary hemostasis or the platelet plug. So as we mentioned earlier, the very first thing that's going to happen is you're going to be having an endothelial injury. So some sort of damage, and that is going to cause the vessel to, you guessed it right, to vasoconstrict. And then what's going to happen is the von Willebrand factor will bind to the exposed collagen, and then this will basically just stimulate even more von Willebrand factors to be released from the Weibel palate bodies. And then the platelets are going to start, binding to these von Willebrand factor, via the GP1B. And then they will undergo a conformational change, which is very, very important. Okay. And I'll let you know in a minute. And then these platelets will release very important things like ADP and calcium. Now, why do they secrete it? Because this will trigger the coagulation cascade, which is basically this one. Without calcium, without ADP, coagulation cascade might lack. All right. So that's something to keep in mind. And they also release thromboxane. Okay. Now, ADP is going to basically help the platelets to adhere to the endothelium. Calcium, thromboxane are pro-aggregators, so they're also necessary for the coagulation cascade. Okay. Now, remember I told you that the minute the platelet binds to the von Willebrand factor, okay, it flattens. Now, when it flattens, it basically also helps it to aggregate, okay, to bind, for the complex to actually show up and be there and, welcome other platelets, okay? I'm talking about GP2B3A, okay? So we stopped at aggregation. Now, the very last part is that the fibrinogen, which binds to the GP2B3A, okay, is going to link these platelets and then cause the aggregation. And then it will form a plug. But this plug is very temporary, very unstable, easily dislodged. So when the platelet plug is formed, the second thing that's going to happen is the coagulation cascade, okay, which is this. Now, you don't really want to know everything in this diagram. However, the things that really are very important for you to know are where each factor belongs, because you might get a question in the exam, the PT is high, APTT is high, bleeding time is high. Okay, you want to know, they might ask you what factor is affected. So we have three pathways in the secondary hemostasis. We have the extrinsic pathway, we have the intrinsic pathway, and we have the common pathway. Now, very first thing that you guys want to know, without calcium, this pathway cannot operate, okay? It's very important to keep in your mind. Now, these are like some easy mnemonics that are just going to help you remember. So for example, for the intrinsic pathway, it's tenet. So you have 12, you have 11, 9, and 8, okay? 7 is lucky, so extrinsic is fast. So in extrinsic, the only thing you want to know is that 7 is there. Tamam? In common pathway, you're going to find factor 10, you're going to find factor 5 as well. Okay, so these are also important to keep in your mind. Tamam? And yeah, so the third thing is fibrinolysis. Okay, so I have this clog formed, right? I have this coagulation cascade, all effective, everything is done. Now, I need to get rid of, this clot that I have. And that's what fibrinolysis is basically going to be doing, okay? So we start off with plasminogen. Plasminogen is an inactive form, which gets activated via the tissue plasmin activator, tissue plasminogen activator, and then it becomes plasmin. Now, the minute it becomes plasmin, This is an active form. So it's going to go to fibrin, and it's going to start degrading the fibrin, which is basically this. Okay, so it will break the aggregates, all right? And basically your thrombin is resolved. Now we have natural regulators. We have things that naturally regulate the fibrinolysis process. So we have TPA, and we also have alpha-2 antiplasmin. Now, if I want to apply this clinically, how will I how do I need to shift my thinking if I want to put this into a clinical perspective? If a patient is having a lot of clots in his blood, right? Fibrinolysis is trying to break down these clots, right? And we see this in DIC, in pulmonary embolism, even in DVT, right? The D-dimer is a product of the fibrin degradation. So if D-dimer is high, this is a biomarker that, okay, then there's something going on, There's probably a lot of clots that are, getting broken down, okay? So this is something to keep in your mind. All right. So just to recap before I go, because I feel like maybe I went a bit too fast. In hemostasis, it's three things: vasoconstriction, and then temporary control, and then the final control. So vasoconstriction, primary hemostasis, secondary hemostasis. The entire purpose of having primary hemostasis, the platelet plug, is to form something that can stop the bleeding temporarily while I activate an entire department called a coagulation cascade for me to build a clot that's irreversible, okay? This happens in a sequence. Now, I personally think that you guys will not be asked a lot of things about it, but you definitely will be asked about what a platelet plug is, and it's part of the primary hemostasis. And of course, these buddies, okay? And then secondary hemostasis. Me personally, I really think just knowing the factors is more than enough, okay? Going into too much details is good, but I don't think it's going to really help you a lot in the exam. All right. Here you want to know about plasmin, D-dimers, very important points. Okay. Now we go to bleeding. So why do we bleed? That's a very good question. So first, could probably be an impaired vascular integrity. There's something wrong with our vasculature, the vessel vasculature, okay? Probably, no proper structures and stuff. Okay, so they can't function properly. Maybe the patient has low platelets, so there's nothing that's going to aggregate, which means that the patient is not going to form clots to stop the bleeding. Or the patient could actually have acquired or probably inherited defects in the platelet, okay? Or also it could be a problem in the secondary hemostasis arm, where, for example, there are some factors that are not there. So imagine if one of the factors are not there, that's a problem because you cannot fulfill the coagulation cascade. So if you keep in mind the 3 steps of hemostasis, okay, every step is going to be affected. If one of these steps is affected, you will bleed, okay? Now, you've probably seen this picture too many times. If you see mucosal bleeding and PTK, I'd say, this is primary hemostasis. Primary hemostasis is basically affected, okay? Just keep that in your mind. So think about it: primary, superficial, mucosal bleeding, PTK, all right? I don't know how you say it. Second thing is secondary hemostasis. So if you see deep bleeding, like bleeding from the joint, like bleeding from the muscle, you want to know that it's a problem with the factors. My clotting factors are not working properly. My coagulation cascade is defective. It's a secondary hemostasis problem, okay? So keep that in your mind. Now, figuring out the problem is very important, okay? And for us to investigate accordingly, we have some pointers that we look for when we do lab tests in a hematological ground, I'd say. So the very first basic thing, you want to look at a CBC. You want to look at a platelet count. The second thing, you want to look at the bleeding time. Is the patient bleeding too much, bleeding too little, or is it normal? You also want to look at the prothrombin time, or PT, and we also want to look at the activated partial thromboplastin time, or APTT for short. Okay. So first of all, platelet count. Platelet count is very important. Anything that's less than 150,000 is considered thrombocytopenia. And when we say thrombocytopenia, basically we're saying low platelets in a fancy way. Okay. We also do this thing called the platelet function assay. So basically, we're assessing the functions of platelet. If it was high, probably indicate that there's a platelet disorder. Okay, so you want to keep that in your mind as well. Now, sometimes we can have false positives. Okay, and I'll show you a very nice example. Now, I'll do a CBC for a patient, and then apparently their platelet turns out to be low, so they're thrombocytopenic. However, when I order a peripheral smear right here, I just happen to see that there's normal platelet. I see platelets, normal count for a smear. So this is what we call platelet satellitism. Okay, it's basically when these platelets are just binding to these neutrophils. Okay. The only reason I'm putting it here, just in case it pops up in your OSPE, you get to know that this is called platelet satellitism. All right. Sometimes in diseases like Bernard-Soulier syndrome, okay, which basically affects the GP1B, sometimes you can have giant platelets on the peripheral blood smear. Okay, so if you see these, please know them. OSPE potential. Anything in Dr. Rehan's slides, any images, OSPE potential. Okay, thrombocytopenia. This is, I'd say, an ocean, but I'm trying to limit it to this one slide. And I think everything in this slide is exactly what you really want to know for the exam. So we agree that anything below 150,000 is considered thrombocytopenic. طيب, جميل جدا. Now, if I tell you that the patient platelet count is between 20 to 50,000, now you want to think that the patient might bleed for a long time secondary to trauma. Okay. However, if I tell you that the patient platelets are less than 20,000, the patient can spontaneously start bleeding. He might just start bleeding out of a sudden. Okay. Keep that in your mind. And mucosal bleed, okay, is also a takeaway that the patient could be thrombocytopenic. So it's not just primary hemostasis that's also defective. You could also think that probably, oh, actually, sorry, hold up. Remember we said primary hemostasis has mucosal bleeding, right? So imagine you don't have platelets for primary hemostasis to actually function properly. So mucosal bleeding also happens. Okay, try to link that up. Patients who have low platelets are at very high risk of bleeding. And one of the things that we commonly see, I think, is the intracranial hemorrhage. And if this happens, it's a life-threatening emergency. Okay. Now, you might ask yourself, why would a patient develop thrombocytopenia? First of all, it could be problem from the machine, bone marrow. Probably there's decreased production. That's one. Two, probably there's some defects in the platelets being produced, causing them to, have low survival. Okay, maybe there's antibodies out there. Or it could be hypersplenism. So when we say hypersplenism, basically we have a huge splenomegaly, and basically they're actively, killing all these platelets. And as a matter of fact, in hypersplenism, which we're going to discuss in a minute, you'll also happen to see pancytopenia. All right. And the last one, which I think is secondary to blood transfusion, is dilution. So imagine you have a patient secondary to trauma presented to you, and they've lost a lot of blood. and you're going to massively transfuse them with blood. That is going to dilute the blood and might just let us think that the patient could be having thrombocytopenia. طيب. So take away 150,000, less than it, thrombocytopenia. 20 to 50,000, patient might have a prolonged bleeding time. Okay, less than 20,000, spontaneous bleeding. Okay, and if thrombocytopenia happens to exist, primary hemostasis will be affected. Cool? طيب. Now, this table is very, very, very important. This will, I'm pretty sure this is going to show up in your exam. Okay, now, how is it going to show up in your exam? Most likely, they're just going to give you a description. They're going to tell you that, oh, the patient came with, for example, PTK, ecchymosis, the pictures I showed you. What grade is this bleeding? So you want to say it's grade 1. However, if the bleeding becomes gross, so you start bleeding from, organs, like you're bleeding from your nose, you're having hematuria, you're having hematemesis, this is grade 2. However, it does not require transfusion. That's a key word. Because if you're bleeding and you require transfusion, that's grade 3. And then you have grade 4. Basically, you're hemorrhaging, you're bleeding with hemodynamic compromise. So when we say hemodynamic compromise, basically we're telling you that the patient's vitals are unstable. So he's hypertensive, he's having low hypotensive, probably he's tachypnic. Okay, so this is a very, very important indicator in grade 4. Even sometimes if they have retinal hemorrhage with visual impairment, if they're having CNS bleed, because these are very fatal, life-threatening. So these are what makes it to be grade 4. And I honestly think it's very easy to remember, but you need to memorize this table. طيب. Now, when we talk about bleeding time, okay, what controls the bleed, if we bleed or not? Platelets. They're part of the hemostasis, okay? So if we have thrombocytopenia or we have a problem with our platelets, okay, either inherited or acquired, then bleeding time will increase. طيب. So whenever you see bleeding time is high, you need to come to a conclusion that there's something wrong with the platelet. It's either not there or it's either not working. One of those. طيب. And very, very common MCQ scenario, basically a patient been taking aspirin for chronically, and they come with bruising, for example, or stuff. You just need to know that they're having an acquired defect in their platelet due to aspirin use. Okay, and you just stop it. Like, now comes to the fun part. I don't think it's fun. It's the coagulation pathway screening. Now, we have three important things that we want to go over. Now, if the PT time is high, طيب, you need to think extrinsic. And who was extrinsic? Factor 7. حلو. طيب. What if we did the factor 7 assay and it was normal? So it could probably be something due to warfarin. So if the patient was on warfarin, their PT time will go high. These are other causes as well. So you have vitamin K deficiency, for example, because vitamin K actually plays a big role in, thrombogenesis as well. Like if they're having liver disease, because that's where the factors are being produced, or if they're having factor 7 deficiency, all of these are going to be, a reflection of a high PT. طيب, think that. So very clinically high yield. Factor 7, warfarin. تمام? Second thing is APTT. So if APTT is high, you want to think intrinsic. طيب. So factor 8, factor 9. طيب. I honestly, from what I've seen in the questions, it's usually a scenario where the patient comes, a male patient, easy bruising, hemophilia A, okay? Or if the patient is using heparin, طيب, their APTT will also increase. طيب. So these are the common ones that I've actually seen. They also increase mildly in von Willebrand disease. طيب. And that's about ABTT. Now, very, very, very important, and this is Dr. Rihan basically telling you, if you get a scenario in your exam that says PT is normal, the ABTT is very high, and you have two choices. You have factor 8 and you have factor 9. What do you choose? You always choose 8, not 9. I'm very sorry. I think you always choose 8, okay? Because hemophilia A is common. I need to double check this one. Actually, I don't remember. Yeah, tamam. Moving on to what if both PT and ABTT are high? Okay. If both are high, then you want to think common pathway. طيب. And when I say common pathway, I just think of, liver failure, DIC, severe vitamin K deficiency, and this is common in newborn. So if you have a newborn who is basically bruised from, just the process of birth, just straight up vitamin K deficiency, okay? Or even in massive transfusion, or if there's factor 5, factor 10, factor 2, or factor 1 deficiency, these are in the common pathway. طيب. So common pathway, you need to think 10, 5, 2, and 1. Okay? All right. So before we proceed, I just want you to guys look at this scenario. So you have a 5-year-old boy presenting with recurrent episodes of mucocutaneous bleeding and multiple bruises, hemorrhages on his body. CBC is normal, including platelet count. So platelet is normal. Coagulation test shows PT is normal, APTT is normal. However, bleeding time is high and his PFA 100 is also prolonged. So we can tell that basically there's something wrong with the platelet, okay? So what do you think your diagnosis is? And what will you confirm your diagnosis with? So I want you guys to think, and we're going to answer it at the end of the lecture. Right. Now, let's talk about thrombosis. So thrombosis is a very, very important concept, especially the virtuous triad. All right. Here we have three important things that you guys want to know. And this is, by the way, very, very common that it shows up on your SAQ. Okay, straight up SAQ concept. Tamam. So thrombosis will happen if blood is not moving, so stasis of blood, or there's injury to the endothelium causing the environment not to operate perfectly, and I would say the patient is in a hypercoagulable state. What do I mean when I say hypercoagulable? I basically mean that the patient is a higher risk of just developing a clot, So these three things: stasis of blood, so not moving for a while. So patients who, for example, have surgery and they're inpatients and they stay in the hospital for too long, there's a chance of developing thrombosis. Okay. Endothelial injury, any sort of endothelial injury, either trauma or not, and hypercoagulability. This is called a virtuous triad. Very important, very high yield. Now, this is a very nice mnemonic that you can use actually to remember the hypercoagulable state, and it's called thrombosis. Okay, so trauma, hormones. So when I say hormones, just think of pregnancy. Okay, very, very common, very high yield, both in USMLE, like when I was doing my steps, oh God, a lot of questions about pregnancy, hypercoagulability, it exists, okay? R is resistance to protein C, and that's factor 5 Leiden, okay? It's a whole thing that we're gonna be talking about. And then obesity as well, malignancy, being on birth control pills can also increase your hypercoagulability state. So if a patient comes in with previous history of thrombosis and she went to be started on a birth control pill, it's probably contraindicated. You don't do that. Okay. older age surgery, and of course, any thrombophilia, anything that basically affects, the primary and the secondary hemostasis could also, alter the balance that we talked about earlier, which could also cause hypercoagulability. And lastly, systemic diseases, okay, like antiphospholipid syndrome, nephrotic syndrome, and so on. Okay, so next thing that we're going to talk about is the anticlotting cascade. Tamam. Now, in the basically, when we say anticlotting cascade, from the name, we're trying to understand that we have a coagulation cascade that we're trying to inhibit. Okay, very important that you guys know this. So you have the TFPI, okay, basically the tissue factor plasminogen activator, and you also have the AT3, and you have protein C and S. Okay, these will basically inhibit the cascade, all right, and prevent you from further making clots. Tamam. Now, I remember seeing this as an MCQ, basically protein C and protein S. Protein C will inactivate your factor 5 and factor 8 to prevent excessive clotting. However, it is activated by protein S. So it's very important for you to know. And as we mentioned earlier, clot lysis can happen through TPA and plasmin. For example, a patient with stroke, the minute they come in through the door, we just give them TPAs. Of course, after a certain protocol, you see if they can, we give them TPAs or not, but usually we give them TPAs so that we can relieve the clot, okay, and alleviate the symptoms. Tamam. Now, I think that was a bit too long. Now we need to apply whatever we learned. Okay, so now we're going to talk about the hemostatic disorders. So how I'm going to be doing this, I want it to be interactive with you guys. So I'll basically be giving you a clinical scenario, and then I'm going to be counting to 3. So feel free to pause the video, try to think of the diagnosis and why it's happening, because basically I'll be talking about them right after I count to 3. Cool? Okay. So, yeah, cool. So our first scenario, a 5-year-old girl presented a pediatrician with PTK, easy bruising, epistaxis, and a history of recent viral infection that happened 2 weeks ago. No splenomegaly was noticed. Family and social history are unremarkable. Let's take a look at her labs. So the patient platelets are less than 30K. PT is normal, APTT is normal, bleeding time has increased, and on peripheral smear, you will see large platelets. We did talk about large platelets, didn't we? So what are we thinking? This is a classical presentation of ITP, okay? Now, basically what happens here is that we are having, usually it happens in children, so 5 years of age, very young, and it's a season, okay? You'll have, and usually a very, very important keyword in your question, recent viral infection that happened 2 weeks ago. 2 weeks ago, I think, yeah. So recent viral infection, children, and you have large platelets on the blood smear, and you have low platelets as well. So thrombocytopenia. This is classical presentation of ITP. Okay, you might ask, okay, why does it happen? Basically, it happens because you're having an active autoimmune destruction of the platelets by forming antiplatelet IgGs in the spleen. Yeah, and they go and attack the platelets. Okay, now, how do we diagnose it? This is a diagnosis by exclusion. Okay, so when you see isolated thrombocytopenia, everything else is normal. And of course, bleeding time is going to be high because thrombocytopenia explains, but your PT is normal, your APTT is normal, everything else is normal. It's called isolated thrombocytopenia. It's going to be ITP until proven otherwise. Now, you can also go further and do a bone marrow if you feel it's atypical, and it's going to show you megakaryocytes, okay? Because if you think about it, low platelets, and basically they're going to urge the bone marrow to keep, like, we need more platelets, like, And basically, the bone marrow is going to be doing things really quickly, and they're just going to have mega karyocytes in there. Now, Dr. Rehan says that you have to do a bone marrow regardless. Why? Because it's a child, okay? And usually in children, you might want to also try to rule out acute lymphoid leukemia. Tamam? Now, usually this is a self-limiting disease. We usually just give the patient some corticosteroids and they're going to be fine. However, sometimes it can last for more than 6 months. And if it's more than 6 months, then it transitions to become chronic. And you're going to be having this extravascular destruction in the spleen. Very important keyword. Okay. This might pop up in your MCQs. This might come up in your SAQs as well. The word extravascular destruction in the spleen is your answer to that question. Dr. Rehan is not going to accept anything else. So you have to keep that in your mind. So how do we treat it? Self-limiting. We can give corticosteroids. If corticosteroids do not work, we can give, IVIGs. And if not, I can just give the patient rituximab. Basically, rituximab is a CD20 antibody. So we can try to have, less IgGs attacking the platelet. And if it's chronic, it's severe, the patient, is not responding, we just have to remove what's producing these autoimmune antibodies, which is the spleen. So we can do the patient a splenectomy. Tamam? I hope you got it right. Now, can ITP present in adults? That's an interesting question. And let me tell you, yes, it can definitely present in adults. However, it's different in the way presented. Usually it's, I'd say, gradual, okay? The patient really does not know they're having something. And it's more common in women of childbearing age. And it's always more than 6 month history of easy bruising. Like they hit, they fell on the floor, they've had like very minor trauma. They're gonna easily bruise, okay? They're gonna have the same CBC result, same bone marrow, megakaryocytes, everything is same. However, and this is important, the pathology here is you're having autoimmune antibodies against the platelet GP2 and 3, okay? So what was that? I think it was Glassman, right? That we talked about earlier. So it targets the GP2-3. Okay. So we're having an issue now with aggregation. This is not self-limiting at all. You have to treat it. Okay. Second scenario. This one is interesting. A 3-year-old boy with lifelong gum bleeding, nosebleed, and prolonged bleeding after minor cuts. CBC showed normal platelet. His platelet function assay was increased. Upon further testing, aggregation test was done, and it showed no aggregation. However, aggregation did not respond to ADP, collagen, or epinephrine. It did work on ristocetin, as seen in the graph. So if you can appreciate in the graph, this is basically just a normal patient. The blue, I think, is normal. The red is our patient. And if you can see that when he was given ristocetin, there were aggregates. Okay. So 3-year-old, lifelong gum bleeding, everything is normal. His platelet function assay is increased, and there's no proper aggregation except to ristocetin. And this is basically Glanzmann thrombasthenia. So I told you earlier, if there's a problem with aggregation, it's going to be GP2B3A receptor problem. There's a defect in that one. Platelets cannot aggregate. How do I remember it's Glanzmann thrombasthenia? It's such a long name. Glanzmann, glued man. I just want to think about it, a glued man, so they can't stick together. That's going to be platelets not being able to stick together. And they respond to ristocetin. This is a very important keyword, and this graph is very important. He might just show it up in an MCQ, even an OSPE as well, all right? Now, the second disease that I wanted to talk about was Bernard-Soulier syndrome. Now, the thing about this, very similar presentation to this one. However, okay, they do not respond to restositin at all. Okay, so this one you want to keep in mind. And again, Bernard-Soulier is an issue with adhesion. Okay, so it's with the GP1B, I think. All right, and basically you're gonna have giant platelets on your peripheral blood smear. Your bleeding time is gonna be high. Your PFA is also gonna be high. And again, guys, don't be terrified when you see PFA 100 high. It just means that there's something wrong with the platelet. That's it. You have a platelet disorder, confirmed. Okay, so don't be terrified. How do I remember this? I just remember it with Big Bernard. Why Big Bernard? Because you're going to have giant platelets on that peripheral blood smear. And giant platelets, no aggregation with restositin. Khalas. Case closed. Bernard-Soulier syndrome. Okay. Third scenario. 15-year-old female student presenting to the clinic with epistaxis and heavy menses, and put 3 bold lines under the word heavy menses. Her elder sister had similar symptoms, so I can say that it's probably genetic. Her platelets are normal. Her bleeding time is high. Her PFA is high as well, and her ABTT is also high. Okay, and her PT is normal. So if I say the APTT is high, then I can say that this could be an issue with intrinsic pathway. Okay, so what are we thinking? This one is definitely going to be von Willebrand factor deficiency. Okay, why? This is a very common USMLE question, by the way. Like I've seen like five to six questions, repeated concept and steps. Basically, a female, heavy menses, okay, and epistaxis as well, usually genetic. When you see the word heavy menses, you have to think of von Willebrand deficiency, okay? This is just like a very old school exam scenario, just to save you the hassle. However, let's work on interpreting why it's von Willebrand deficiency. So, first of all, her APTT is high, so I want to think could be factor 8, could be factor 9, right? Okay, her PT is normal, so her factor 7 is okay. She's bleeding. Bleeding time is high. PFA is also high. Understandable. There's something wrong with my secondary hemostasis. They're not working properly. Okay. Sorry, my primary hemostasis, because platelets are not binding. You know, nothing is causing clots to form. Okay. So how I like to remember it, von Willebrand, VWD. So von, vessel. So my primary bleeding is affected. Okay. V, now it's the W here is pronounced in the German way, so it's V. So V for factor 8, okay, factor 8 deficiency affecting my secondary bleeding. D, double homicide. You need to know in von Willebrand disease, it's 2 things are being affected, both your primary and secondary. But let's talk about it. Why? Why does it happen? If you think about Willebrand, think of Volkswagen, the car brand. It's a car, right? And car carries people. Von Willebrand carries factor 8. Without von Willebrand, factor 8 is going to be lonely and it's basically going to kill itself. Okay? It's literally going to die. So it's like a toxic relationship, if you think about it. So they have to be there. If there's no von Willebrand factor, there's no factor 8. Okay, they come hand in hand. It's an autosomal dominant disease, and yeah, this point that I just mentioned, extremely high yield. I'm 100% sure Dr. Rehan is going to get a question. And there are 3 types. You only need to know type 1 and type 3. Type 1 is a partial deficiency. Type 3 is complete deficiency. Now, you might tell me, Ismail, why do I need to know them? Because the treatment is different. For type 1, we give them D-amino D-arginine vasopressin, which is DT-AVP. I don't really know what it is, but you have to just, whenever you see it, just know it's the treatment for type 1 von Willebrand disease. Basically, what it does is it goes to these Weibel pallid bodies in the endothelium, and it just triggers it to increase its release of factor 8 and von Willebrand factor. Good thing. Amazing. Now, can I give that medication to type 3 people? No. Why? Now, you might come and argue, why? Why not? Because it's a complete deficiency. There's no von Willebrand factor. And in this situation, I have to give them, external von Willebrand factor and factor 8. So I can just easily give them a cryoprecipitate, or I can just give them plasma derivatives of factor 8 and von Willebrand factor concentrate, and they can just, live on their life. However, we will get a problem for giving patients factor 8 for a long time. All right. And I'm going to be discussing that very soon. Scenario 4. So we have a 3-year-old boy with painful swollen knee after minor trauma, multiple episodes of prolonged bleeding after vaccination. His PT is normal. His APTT is very high. His BT is normal. His factor 8 level is low. But this is a very classical scenario. It's a boy. It's a young boy. His factor 8 levels are low. However, everything else is normal. His APTT is actually very high as well. And basically, he bleeds and bruises from the simplest thing that could happen to him. This is hemophilia A. Okay. Like hemophilia A, now hemophilia A and hemophilia B they present the same way. It's just the different deficiencies. Okay. Hemophilia A is طبعا more common in males. We rarely see it in females. And also hemophilia A is like way more commoner than hemophilia B. Okay. Like the way they present is very specific to them. They will have hemarthrosis, very common, which is exactly what happened with our patient, painful swollen knee. They'll also have soft tissue hematoma. So, the patient's having prolonged bleedings after vaccination. Okay, the patient could also have other sites of bleeding, like, for example, hematuria. The patient could have intracranial hemorrhage as well. But the most common one that you want to know, hemarthrosis, soft tissue hematoma. And if, for example, they had any surgery, vaccination, dental extraction, they're going to bleed severely. Okay. Now, severity is very important to know. And I took the screenshot from Dr. Rehan's slide because he said that it's very important that you guys know it. Because based on severity, we treat the patient. And basically, related to factor level. So if the factor level was mild, so between 5 to 25%, here you'll have the patient bleeding with surgery or trauma. If it was moderate, 1 to 5%, he will bleed with any mild injury that happens. If it was less than 1%, this is extremely severe and the patient could spontaneously bleed. And this is life-threatening. Now, how do we treat this patient? We give the patient factor 8 concentrate. Tamam? Tamam. Hemophilia B, same exact presentation. However, it's factor 9 deficiency. And they're both in the same pathway, so you will understand why they're common in the way they present. However, there is a complication of treatment. So look at this. Patient comes in. I know he's having hemophilia A. Always choose hemophilia A. Okay. So back when I told you I was not sure, I'm sure now. Okay, always choose hemophilia A. If there's low factor 8 or there's hemarthrosis, bleeding tendency, it's a boy, hemophilia A على طول. Okay. Now, you give the patient factor 8 concentrate, and after a while, the patient comes in and he's bleeding again, as if you did not give him treatment. What do you think might actually happen with our patient? So, basically, you did a correction test. You know what's a correction test? It's basically you take the patient's plasma and you mix it with a normal human plasma, and whatever issue, okay, is supposed to get resolved the bleeding, for example, to stop, or, here it did not. Okay. ATTP is still high. Okay. What would you do? What would you think could be the cause? And it's written on the slide. So basically, when you give the patient for a long time, like chronically, give them factor VIII for a long time, the body will just develop antibodies against factor VIII. So this means whatever factor VIII we give, it will get destroyed because of the antibodies. Okay. And that's a complication of the treatment. So that is something that you guys want to think of. Probably going to show up as an MCQ. So a scenario would come in, patient with hemophilia A, you give them treatment, they come after a while, not working out, ATTP still high, correction study done. Why? Antibodies against factor VIII. That's all you need to know for this level. Like, newborn with bleeding from umbilical stump. I don't want to give you any seconds because this is classic presentation of vitamin K deficiency. Automatically think, newborn. He just, came into life and he's bleeding from an umbilical stump, vitamin K deficiency. على طول. Okay. So how do I remember this? Vitamin K is made in 1972. So vitamin K is essential for factor 10, 9, 7, and 2. طيب. So imagine if vitamin K is not there. The entire department is down. طيب. So if the patient was bleeding actively, like he's born and he's bleeding, you want to give them fresh frozen plasma, and then you give them vitamin K injection. However, and we do this, by the way, in practice, like inshallah, when you guys come to 4th year and do OB-GYN, you'll see that every newborn in pediatrics, every newborn we get, we inject them with vitamin K. طيب. It's like a protocol. Anyways, let's say that the scenario is very long. They're probably going to tell you the PT is high, APTT is high, everything else is normal. طيب. So bleeding time is normal, platelets is normal because it's not affecting the platelets. طيب. It's not affecting the, I'd say, the primary hemostasis as much as it's affecting the coagulation cascade, the clot forming. So PT is going to be high, of course. APT is going to be high, of course, because all of the factors that are, being deficient because vitamin K is not there. طيب. Very easy. Do not lose marks because of this. طيب. Okay. So I think 2 scenarios are left. So we have the scenario number 6. So a 24-year-old woman presenting with sudden onset left calf pain, swelling that began 8 hours ago. Sudden onset is a key word. She recently returned from a long-haul flight. Okay, so she was immobilized for quite a time. Her medical history is significant for 2 first trimester miscarriages. Okay, there is no history of abnormal bleeding. Her father had DVT at the age of 45. On examination, her left calf is warm, swollen, and tender. There are no petechiae, no mucosal bleed. So that can tell me that the patient platelets are normal. Thank you very much. The PT is normal. APTT is also normal. D-dimer is elevated. Coagulation panel is normal. And the activated protein C resistant assay is positive. Now, I can just close my eyes and say factor V Leiden. Now, you'll tell me what, why? How do you know? Activated protein C resistance positive, factor V Leiden. Right? Automatically. And this is very common. The scenario that I just showed you is very common. And as a matter of fact, this is the most common hypercoagulable disorder. I've seen it in steps. I've got it wrong as well. The question they asked was, what mutation happens in factor V Leiden? And it's basically the glutamate just changes to arginine. And this is why there's resistance to the activated protein C. You only treat if they're having a thrombotic episode. Is this patient having a thrombotic episode? Yes, it is. Why? Because they're having sudden onset left calf pain, long-haul flight. They've been immobilized for a while. So I would definitely think that there's DVT going on. Okay, so I would definitely treat this patient. Okay, but you only treat if there's a thrombotic episode. Like, it's very important, by the way. Our last, I think this is our last for hemostatic, yes. So 29-year-old woman presenting with sudden onset right leg swelling and pain. Again, sudden onset right leg swelling and pain. She also reported 3 consecutive miscarriages at 12 to 14 weeks. So I would say, in her early trimesters, past medical history include diagnosis of mild lupus made 2 years ago, but she's not on treatment. No personal or family history of bleeding disorders. On examination, her right calf is swollen, warm, and tender. Okay. No fatigue, no purpura, no mucosal bleeding are observed. Her platelets are mildly low, so there are 110K. طيب. So not thrombocytopenia, because thrombocytopenia is less than 150. Her PT is normal, her APTT is prolonged. And the mixing study does not correct. So the correction study does not correct, and her D-dimer is elevated. So mildly low platelets, consecutive miscarriages, D-dimer is high, APTT is high. What do you think is going on? This one is a classic scenario. I got this from USMLE. Okay, antiphospholipid syndrome. Classic. How will I know? Very easy. First of all, it's a classic triad. The patient is going to come in with thrombosis, okay, pregnancy loss, and thrombocytopenia. Now, you might tell me how the patient has thrombosis. Basically, when you see sudden onset right leg swelling, which is warm, swollen, and tender, I'd immediately think that this probably could be DVT, okay? And the patient does have thrombocytopenia. I don't know what's wrong with me. 110 is less than 150. So yes, thrombocytopenia, okay? And pregnancy loss, the consecutive first trimester miscarriages is a classic giveaway that this is an APS, okay? APS, antiphospholipid syndrome, and thrombocytopenia as well. Now, other things that you'll also find positive: anti-cardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, and lupus anticoagulant. And this patient actually has lupus. So that's also another indicator that should make you think that this could be an antiphospholipid syndrome. Also, because they're having a lot of thrombosis going on, and they have this microthrombi, so they can also present with livido reticularis. Tamam? How we treat the patient with heparin, warfarin. Heparin is first line. Now, what you really want to know is exactly in this slide, nothing else. Classic triad, the antibodies present, and the livido reticularis and treatment. Yeah. Okay. Very important that you know these antiphospholipid antibodies. What do they target? They're targeting your protein C. They're targeting annexin 5. They're targeting beta-2 glycoprotein 1. And I think it makes sense, because we have anti-beta-2 glycoprotein 1 antibody. So this can help you remember this one. Very important slide. And Dr. Rehan said it might come as an SAQ. And I think he did ask people previously, and they left it empty. Okay, so protein C, annexin 5, beta-2 glycoprotein 1 are basically the targets of antiphospholipid antibodies. Tamam? And with that, I conclude hemostatic disorders. Now, I'm going to move on to spleen and some other topics. Inshallah, this section is going to be very easy and very quick. I'm so sorry if I'm taking too much of your time. So, spleen. Spleen is an organ that we have, okay? It's a very, very important organ in clearing encapsulated organisms. This is extremely high yield that you guys want to know. Now, what are the functions? It does produce lymphocyte, and basically all the trashed RBCs in our blood, gets picked up and removed in the spleen. Basically, it also makes antibodies, okay, like the autoimmune antibodies we just talked about in a minute. It also store platelets and also kills platelets. Tamam. And recycled iron as well. Now, this is just an intro for the upcoming slides. So splenomegaly. Now, when I say splenomegaly, I have to be very careful because splenomegaly and hypersplenism, I find these two words used by people interchangeably, and that's completely wrong. When I say splenomegaly, I mean that the spleen is just large. And when I say large, more than 12 centimeter, and there could be multiple causes. So the very most common cause is congestive, infection, hematological diseases, autoimmune like lupus, storage disease like Gaucher. Like, when we say congestive, I want to think portal hypertension. I want to think right-sided heart failure, cirrhosis, splenic vein thrombosis. This is usually seen with pancreatic malignancy. Okay. By the way, portal hypertension can also happen due to right-sided heart failure because the blood is just, backflowing. Infection, of course, infection like malaria, schistosomiasis, EBV, HIV, tamam. Hematological diseases like lymphoma, myeloproliferative neoplasm, thalassemia as well. Now, hypersplenism. When I say the word hypersplenism, you want to think of three things. Yes, splenomegaly. However, the patient will also have cytopenia and hypercellular bone marrow. Let's just take a breather and understand what's going on. Basically, the patient will come with a very large spleen, and that large spleen is basically chopping up all these different cells in the blood, causing the patient to be cytopenic. So the patient is going to have like pancytopenia. And because of that, this will trigger the bone marrow. Like, hello, we need, platelets, we need RBCs, WBCs, like we're out of stock. And this will basically put the bone marrow at a hyper, hyperfunction. And basically it's going to become hypercellular, okay? Just as a compensation. Tamam? So this is the idea behind hypersplenism. So you need to be very careful when you use these two terms. And they're not interchangeable. But now let's tackle some scenarios. And trust me, these are the last scenarios we have in today's presentation. So the first scenario is a 68-year-old man presenting with fatigue, diffuse bone pain, and recurrent respiratory infection. Diffuse bone pain, recurrent respiratory infection. Keywords. His labs show hypercalcemia. His creatinine is 2.1, okay, elevated. His hemoglobin is 8.4, and his total protein is high, and his albumin is low. So I can understand why his albumin is low, because, oh wait, we're not yet at the diagnosis part. So you've ordered a peripheral smear, and basically it showed you this stack-like looking RBCs, okay? And then the team also decided to order a skeletal survey, and it showed you lytic lesions right here, basically the bone eating up. And also you did a bone marrow aspirate, and this is what it showed. So what do we think is going on? This is multiple myeloma. How do I know multiple myeloma? ONC. CRAB. Hypercalcemia, renal failure because high creatinine, the patient is anemic, and he's having bone lesions. This is a takeaway that the patient is having multiple myeloma. Tamam? Now, also, it's usually accompanied with patients who have recurrent infection. Like it's a keyword. It's part of the diagnosis for multiple myeloma. Now, when you see something like this is called roulet formation, not Rolex. Okay, Dr. Rehan strictly said, if you say Rolex, if he ever catching you saying Rolex, you're done. So don't say that. So the roulet formation, stacking. Now, why does this happen? First of all, we need to understand what really happens in multiple myeloma. In multiple myeloma, basically, you're having plasma cells producing, immunoglobulins. Basically, there's a defect in the plasma cell that's causing it to to produce monoclonal, which means only from one plasma cell, these IgGs, immunoglobulins. Now, usually, the red blood cell has its zeta potential, which basically it has negative charges that causes it to repel from each other. When you have monoclonal immunoglobulins, what happens is the negative charge basically decreases. So the RBCs stack on each other. And that's exactly why this happens. Okay. Now, we said that there's many plasma cells, right? And this is also witnessed on your bone marrow. Now you can see these deep blue cytoplasm cells with a punched out nucleus, a lot of plasma cells, as you can see. Now, of course, you want to be, sure that these are plasma cells, or else you can just misdiagnose the patient, and it can happen. So for us to be sure, you can confirm by ordering CD138, and it's going to be positive because they are present on plasma cells. And the lytic lesions that we just saw are also due to proliferation of plasma cells into the bone marrow. Okay, so I just said it to you guys. Again, recap, we have a bone that has a marrow, bone marrow. Usually the plasma cells are produced and they produce polyclonal antibodies, polyclonal proteins. In multiple myeloma, there's abnormal growth of plasma cells producing monoclonal proteins. So in your serum, you're going to find monoclonal proteins. Keyword, multiple myeloma, M. Multiple myeloma, monoclonal proteins. How do I diagnose? The patient must have the M protein that we just talked about, monoclonal protein, more than 10% of plasma cells in the bone marrow, and an end organ damage. Remember the crab that we talked about? That's the end organ damage that we're talking about. And also, I don't know if I explained it. Yeah, this one right here. Basically, this is a protein pheresis. Okay, protein pheresis. And basically, you can see that this spike right here so the normal pattern is the blue one. The purple one is the abnormal pattern, basically the patient with multiple myeloma. You can see that they have a huge spike of the gamma globulins, and this is due to monoclonal proteins, okay, due to the abnormal plasma proliferation that's happening. How do you treat? Your goal is not to treat in a curative way. However, our goal is always to control the symptoms. Tamam? So if your patient is less than 50, you will offer them allogenic stem cell therapy. If the patient was older, you will offer them chemotherapy and dexamethasone. And in case of hyperviscosity, you can give the patient plasmapheresis. And also biphosphonates are an option because they basically increase osteoblastic activity, which strengthen your bone. Tamam? Okay. I hope that was fun for you guys to learn. I hope it was interactive. And I would appreciate your feedback on these scenarios. Our second scenario is a 29-year-old man presenting with dark cola-colored urine in the morning, fatigue, abdominal pain, low hemoglobin, very high LDH. His haptoglobin is undetectable. Indirect bilirubin is elevated, and his platelets are normal or low as seen. And if you can also appreciate the picture, the arrowed ones, his urine dipstick is positive for hemoglobin, negative for RBCs. The flow cytometry shows absence of CD55 and 59 on blood cells. I think I just told you the answer. So what do you think this is? This one is paroxysmal nocturnal hemoglobinuria. What is PNH? First of all, the name does not mean what's really happening. Okay, when we say paroxysmal, it's episodic. It doesn't happen continuously. It's an episode. Nocturnal hemoglobinuria does not mean it happens at the night. It's just that the patient wakes up and basically the blood, urine is basically, static in their bladder. And when they pee, it's just dark because, they're oxidized and everything. He just happens to see it more vividly. So a patient is going to come to you with hemolytic anemia, hemoglobinuria, and his bone marrow is failing. They're having neutropenia, they're having low platelets. Now, let me just go back to the scenario. I just want to explain to you the labs. Low hemoglobin, okay, understandable. The patient is having hemolytic anemia. طيب. LDH is high. When you see the LDH is high, you need to know that basically the RBCs are getting chopped. طيب. So high LDH, low hemoglobin, undetectable haptoglobin will all direct me that there could possibly be something wrong with RBC clearance. So maybe there's hemolytic anemia. طيب. Also, his bilirubin is elevated. تمام? Indirect bilirubin. And we saw hemoglobin in his urine, so hemoglobinuria, and his CD55 and CD59 were absent on the cells. This is very important. Why? Because what happens is that the patient will acquire, so they're not born with this, they just happen to acquire a lesion in a mutation in their PIGA, okay, and this will cause deficiency of CD55 and CD59. This is going to cause the complement cascade to basically go and perform hemolytic anemia. So they're going to have complement-mediated intravascular hemolysis. Okay, Dr. Rehan said you do not want to know more than this. However, I'm just going to briefly brush on what really happens. CD55 and CD59 inhibit the C3 convertase and also will inhibit membrane attack complex. Okay, and it's going to basically just inhibit the fact that, you know, complement cascade can go and just kill those innocent RBCs. Okay, so when you have a mutation in the PIGA, basically your CD55 and CD59 are lacking. They're not being produced, so they're not safe, they're not protected, and basically the complement are just gonna pick them up as like foreign, and they're just gonna basically start doing an intravascular hemolysis. That's all you want to know. How you treat again supportive. طيب. Supportive treatment, you give the C5 inhibitor, eculizumab. It's a very good if you remember this. To cure this, we give the patient bone marrow transplant. Now, these patients usually live 14 to 22 years, after the diagnosis, but they usually die. And the death happens due to a thrombotic episode in severe cases. There's a certain pathway. There's more into it. Honestly, never covered it, never studied it. I personally think it's way too advanced, and this is all you want to know. So one of the complications of having a PNH is dying from thrombosis. And of course, infection, because you're having bone marrow failure. Like, I think this is our last scenario. I'm not sure. So this is a 32-year-old woman presenting with confusion, PTK, and abdominal pain. Her platelets at 18,000. Okay, that's not good. Because what do we say? Anything less than 20, spontaneous bleeding. Yep. Her hemoglobin is 7.9. We have schistocytes on smear. As you can appreciate, these are schistocytes. Her LDH is high. Her haptoglobin is low. So there's chopping up happening. Normal PT, normal APTT. Forgot to put the A. And the creatinine is mildly elevated. So what are we thinking? Confusion. So basically, we're having neurological symptoms, abdominal pain, PTK as well, and very, very low platelets. So this is thrombotic, thrombocytopenic purpura. So we can just appreciate from the symptoms, PTK, purpura, thrombotic, because the patient has very low platelets, and thrombocytopenic, the patient has very low platelets. How will they present? Fat right now. Okay, that's how I remember it. Fat RN. They're going to present with fever. They're going to have anemia. Okay, and the anemia is MAHA. So the microangiopathic hemolytic anemia with schistocyte. They're also going to be thrombocytopenic. and they're going to have renal involvement, which we saw the creatinine was mildly elevated, and they're also going to have neurological symptom. Very important differentiator from the HUS, okay, which is the hemolytic uremia, I think, syndrome. So basically, it does not happen there, but it happens here in TTP. طيب. Now, very important, SAQ potential 1000, okay, extremely high aura disease, by the way. You need to know that there is an antibody that's basically going to fight against ADAM TS13, and basically this will prevent the cleavage of the UL von Willebrand factor, which is a multimer, which is really big. And they're going to keep on accumulating. And as they accumulate, the platelets are going to stick. صح? Because they have the von Willebrand factor. Platelets are going to stick. While they stick, they're going to be forming these microthrombi, and this will lead to organ ischemia. Okay? Then, the RBCs are also going to shear against the clot. And when that happens, you get schistocytes. And due to schistocytes, the spleen is going to take them. Okay, you're not good, buddy. You're done. Chop it up, hemolysis. You're also going to have platelet consumed. Okay, so the platelets are also going to be consumed, right, in the process because they're sticking and stuff. That's why the patient is also going to have severe thrombocytopenia. Hence, thrombotic, thrombocytopenic purpura. So, ADAM TS13 is not there anymore. The VWF is accumulating. Platelets are going to stick to it. Microthrombi, so that's thrombotic. Thrombocytopenia, because they're sticking to it, very low. Platelets, thrombocytopenic. Purpura, thrombocytopenia, we mentioned mucosal bleeding. RBCs are going to shear against those clots, schistocyte, hemolysis. How do you treat? Plasmapheresis, your best option. We also give steroids, but steroids are not that effective in TTP. Okay, very, very high yield disease, extremely high yield disease. And we are done with the, I would say the heavy part of today's crash course. And now we're going to go over blood transfusion. Now in blood transfusion, I covered 3 lectures. I cover, the blood transfusion lecture by Dr. Sabri. I covered the adverse effects of blood transfusion and stem cell therapy at the very end. Okay, Bismillah. If you want to take a break, go on. I'm going to start. So I went through the doctor's lectures, and I honestly just come up with some points that I think might show up on your exam. Since this is a crash course, and I'm just trying my best to be very on point. So first of all, you want to know that safe blood is blood that does not contain any foreign material or any substances that can cause risk or disease into the patient who's going to receive it. And basically, you want to know how to have safe blood. What are the protocols? So, of course, you want to know that there's correct transfusion indication, proper selection of donors. You also want to know that they're storing the blood properly, and of course, infection safety. This is, I think, the part where MCQs might pop from. So you want to universally screen for hepatitis B, hepatitis C, HIV, syphilis, because these are very easily transmissible through blood. And of course, the very simple thing that you want to do to a patient is you want to ask for their past medical history, their medication, if they have to travel. Because if they go to endemic areas, we don't take their blood. Keep that in your mind, okay? And if the patient is a neonate or if the patient is immunocompromised, we have to test for CMV. Now, I think this is really high yield and you guys want to know it, okay? So if the patient is immunocompromised or if the patient is neonate, you have to test for everything and CMV, okay? Then we have the parvovirus. We usually look for it in patients with hemolytic anemia because if it's there, it's just going to cause an aplastic crisis. And lastly, you want to add the anti-hepatitis B core antibody And you also want to use the nucleic acid testing, BCR, to improve HBV sensitivity, which I'm going to talk about in a minute. And of course, serological safety, transfusion, and following up with the patient. Okay, I think this is self-explanatory, but just for the sake of completion, I put it here. This is the part where I think you will get questions. I'm pretty sure you will. So it's very important that you understand what we mean when we say sensitivity, what we mean when we say specificity, and the window period in blood screening. First of all, sensitivity. Simple term is the ability of a test to detect that this donor is infected. Okay, it's sensitive. So the higher the sensitivity, the higher the sensitivity is, few false negatives are going to be there. So when we say sensitive, this means I'm detecting that the patient does actually have the disease. Okay. However, when I'm saying specific, I am, detecting that this patient does not have, the disease. And basically, the higher the specificity is, the less false positive is going to be there. So, is every test really crazily specific? Not really. Okay. And it depends on so many factors. And when you're transfusing blood, you don't want to play with fire. So all positive screens. So for example, let's say, yes, it's positive that this patient, wallah, does not have the disease. Okay. I'm going to confirm. How do I confirm? I do the NAT, nucleic acid testing. Very, very important. But you might tell me why. I'll tell you exactly why. In the window period, this is a time between the infection actually entering your body. Okay, so you actually contracting the infection right here, and the time that the body actually starts producing antigen for these specific pathogens that enter your body. That time between contracting the infection, like you're actively infected, but we can't detect it yet because there's no antigen. And between the time the antigens are produced, this is called the window period. Extremely important. I cannot emphasize how important this is for your steps and for your exam. Okay, so when the virus is present, but the surface antigen is not detectable, antibodies are not yet formed. This is extremely dangerous because if the patient has, sexually transmitted infections, they just contracted it, it's an issue. Now, what do we do? I want to confirm that this patient actually is not infected. I do nucleic acid testing, and this can detect for me the viral DNA directly. Very important point, and I really hope that I explained it in a simple way because sometimes it tends to be complicated. Anyways, moving on to compatibility testing. I think this is very self-explanatory. We've done it in first year. You don't just give blood randomly around. You want to check for a blood group, and you want to also cross-match, okay? Now, you don't really want to know everything here, but you want to know something. If the patient cross-match is compatible, you will have no agglutination, okay? No agglutination. However, if it's incompatible, they're going to agglutinate, okay? Very important. Something else that you also want to know that Dr. Sabri emphasized in his slides is the direct comb and indirect comb. Okay, direct comb, basically there's antibodies on the RBC surface. Indirect comb is basically antibodies are free in the serum, and we can use them for screening and cross-match. Please memorize these. Now, leukoreduction. Leukoreduction, as simple as it is, I am just removing leukocytes from my blood. Why? Why do I need to do that? Because sometimes the blood we can have an adverse effect. We call it febrile non-hemolytic transfusion reaction, where basically the blood just is sensitized from the leukocytes in the donor blood. Okay, and how that happens, basically the cytokine from the donor lymphocyte are going to be released, and they're basically going to do this entire febrile transfusion reaction. Okay, that's one thing. Second thing, you reduce the risk of CMV transmission. Why? Because some viruses are intracellular and they can just still live within the WBCs. So you're basically just transmitting the infection to someone else. Okay, and it would also decrease the alloimmunization, which is very important for chronically transfused patients. Like, honestly, my main takeaway that you know what liquid reduction is, and you also want to know that we do it to just prevent any complications like infection and complications. Okay, easy. Now, irradiation of blood content. Why do we irradiate the blood content? Basically, and the only reason is you do this to prevent any rejection from the recipient. So any transfusion-associated graft versus host disease, this is why we do irradiation. Okay. Now, what does it mean when I irradiate? It's basically saying that I'm just inactivating any donor lymphocyte. So let's say I did liquid reduction, but maybe there's some lymphocytes still are there. I just inactivate them by doing irradiation. Okay. Now, when do we do this? We do this, I think they just in like most centers, I think they do it. I'm not sure, but you do it for the patients that you want to be extra safe with, immunocompromised, or if it's intrauterine, or if it's a neonatal transfusion, or if it's a transfusion from relatives. Okay. Why? Because they have higher risk of graft versus host disease. Like apheresis. Oh, apheresis. Very important concept because we're going to be talking about it later on. Apheresis is basically you take the only component that you really need from the blood. So blood taken from donor, the machine will separate a component and then you return the rest to the donor. خلاص. For example, I want your plasma. Okay, I'll take the entire blood. I'll filter out the plasma, take the plasma, and return the blood to you. Okay. Like imagine you have a $10 bill, a $5 bill, and a $1 bill. I only need your $5 bills. And you gave me your entire, let's say, money in your wallet. I'll just pick whatever $5 bills I want, and I'm going to return the rest to you. Okay. Yeah. Therapeutic apheresis is basically when you do it to remove harmful components from the patient. So for example, we've talked about it, like plasmapheresis in TTP, or if you want to remove excessive leukocytes in leukemia. Okay. And yeah, the last one is apheresis platelets. Honestly, I have not seen any question about this, but the idea is that you take platelets, okay, and basically whatever platelets you take from this donor is equivalent to 6 to 8 random donor units from whole blood. So it's that concentrated and that helpful, okay? And the only advantage we see from this is that there's less infection, less immune risk, because it's a single donor exposure. You know what I'm saying? So it's really great. Apheresis is a really, really good thing that is practiced in blood transfusion. But this one is from our beloved first aid. The only reason I put this here is that you guys can understand what do we mean by these different things. First of all, I want you to know that we rarely transfuse whole blood. I mean, I don't think we do that at all. Okay. Now, you want to know, we do give packed RBCs. When do we give packed RBCs? For example, patients in surgery, we give packed RBCs. I don't transfuse whole blood. Okay, the only reason I do it if there's any acute blood loss or if there's any severe anemia. Platelets, I only give platelets to stop significant bleeding. Okay, because for example, if only if the patient is having thrombocytopenia. I give fresh frozen plasma. I give prothrombin. I can give these complex concentrates, in situation where I need immediate anticoagulation reversal. So I have like a lot of anticoagulation happening. We talked about it, the neonate bleeding. He's actively bleeding, right? And I need an immediate anticoagulation reversal. I give the patient fresh frozen plasma, and then I'm going to give them vitamin K, okay? So it's basically just going to increase your coagulation factors, okay? So it's basically will help in your coagulation. So yeah, and we can also give certain factors, like for example in hemophilia A, when they don't have no managed hemophilia A, any of these, if there's anything wrong with these factors and they want it, we can just give them to through fresh frozen plasma, prothrombin, complex concentrate. Second thing is the chiroprecipitate. This is where we give factor 8 and factor 13. Tamam. We basically give it to patients who have it deficient. Albumin, I give it when? I give it after I do, for example, therapeutic plasmapheresis, and I also give it after paracentesis. Why? Because I need basically the intravascular volume to increase and the oncotic pressure to increase, and albumin plays a very, very critical role in achieving that. That's all that you want to know. And I don't think you even want to know it in details. You just want to know that these exist. Okay. Okay. Let's now talk about blood transfusion reaction. So I think we need to just go quick through those. So the number one cause of any serious transfusion reaction is a clerical error. Right? It's a human error. We mix up the patient, wrong bag, mislabeling. All of this is a clerical error. Tamam? You need to remember that very well. Now, acute transfusion reactions, when we say acute, they happen within the first 24 hours, and we have all of these that could happen. So it could be just a febrile reaction, it could be an allergic reaction, or it could be something that is affecting the lungs, like the TACO and the TRALI, which I'm going to talk about in a minute. Okay, so the very first one is called acute hemolytic transfusion reaction. And the number one cause is clerical error. So when hemolytic happens, when hemolysis happens, agglutination happens, basically the blood is incompatible. طيب? You need to keep that in your mind. But what happens? I'll tell you what happens. So you have an IgM plus antigen. This will activate your complement, and this will start your membrane attack complex. طيب? So right here, activate your membrane attack complex, and then it's basically gonna, mediate hemolysis immunologically. So you're gonna have a cytokine storm of, interleukin 1, interleukin 6, TNF alpha. This one is gonna cause the patient to become febrile. You're gonna have thrombosis, and you can actually end up having DIC, disseminated intravascular coagulation. Also, it will cause mast cells to release histamine. So the patient can also develop bronchospasm and hypotension. So a potential question will definitely probably come that why the patient's having bronchospasm, mast cell histamine release. Okay. Also, due to hemolysis, you're going to have free hemoglobin, and this will also cause kidney injury. Okay. And the IC, as I also mentioned, and that's about it for intravascular hemolysis. Okay. Clerical error, because why? Because the blood was incompatible. So, yeah. Now, we've explained how they present clinically. Lab-wise, it's hemolytic. So your haptoglobin is going to be low, your LDH is going to be high, and your indirect bilirubin is also going to be high, and the DAT is also going to be positive. I think these are very self-explanatory. So if you see this combination, just think of hemolysis. Okay? Right. Now, this slide was tend to ask you guys, what do you do if the patient was having an acute hemolytic transfusion reaction? You will immediately stop transfusing. That is your treatment. Okay? Like, second thing is the transfusion-associated sepsis. Now, the reason is platelets, as I mentioned earlier. Okay? Why? Because platelets are usually stored at 22 degrees Celsius for 5 days, and they're constantly agitated, and this will basically give room for bacteria to grow freely. Now, the patient is going to come to you with rigors, okay, shivers. The fever has increased by 2 degrees. They're hypotensive, they're in shock, so they're hemodynamically unstable, and they have an altered mental status. Now, for you to confirm the diagnosis, you're going to take blood culture from the patient. So let's say you transfuse them from your left, you take them from the right, and you also take culture from the bag that the donor blood, the bag that had the blood. You just take culture from it and take culture from the recipient, and they're both are going to have the same organism, and that's how you confirm that a patient's having transfusion-associated sepsis. How you manage? Antibiotics, and of course you need to notify the blood bank because other people might also be having the same issue. Now, febrile non-hemolytic transfusion reaction, okay, or FNH for short. This one is very straightforward, Okay, and I think we've already, covered it. First of all, the patient needs to have at least 1 degree Celsius fever and increase, no hypertension, no hemolysis. It's different from your transfusion-associated sepsis. Okay, here the patient is hemodynamically unstable. Here they're hemodynamically stable. It's only their fever that's increasing. Why this happens? Because basically the blood they gave the patient was not leukoreduced, meaning that the lymphocytes were there, they were active, they were releasing cytokines. These cytokines are basically causing the fever to happen and stuff like that. Okay, so how do you prevent? You leukodeplete. Okay, how do you manage? You give the patient paracetamol and you continue the transfusion. There's no harm on the patient. It's just cytokines messing with him. That's it. Okay, keep that in your mind. Very, very, very important. Management, you continue transfusion. So, now, it could be an allergy reaction. Anything that we put in our body, foreign, we could be allergic to. So first of all, we can be allergic to the blood in a mild way. So you're gonna come in with itching and hives, and basically you're gonna give the patient, just antihistamine, and you continue your transfusion. However, if the scenario changes and the patient becomes hemodynamically unstable, okay, then this is severe or anaphylactic. You need to immediately stop the transfusion and need to give the patient epinephrine. Tamam? Now, this is most commonly seen in IgA deficiency. So if a patient is IgA deficient, you need to give them blood products specific for IgA deficiency. And I think this is very self-explanatory, inshallah. Second thing is TRALI, transfusion-related acute lung injury. So now this one is very, very unique. It happens in the first 6 hours of transfusion. So you're going to have basically the donor anti-HLA antibodies, the anti-HLA and the anti-HNA antibodies. They're going to bind to your neutrophils and they're going to activate the neutrophils. And when basically neutrophils are activated, they're going to go and do pulmonary endothelial damage. And if you can appreciate this chest X-ray, you can see that the lungs are infiltrated bilaterally. Okay, and the patient basically probably is having an edema. They're hypoxic. Their lungs are not functioning properly. The endothelial line is not functioning properly. Okay, they're going to be dyspneic because they're grasping for air. They're going to be hypotensive. They're going to also be having pink frothy sputum. This is sorry. In this one, you don't have any overload. It's just your lungs getting attacked. That's it. Okay. And your BP is going to be really low. This is a very, very important key differentiator from taco, number one that we're going to be talking about, but not the Mexican taco. How do you manage this patient? You give them oxygen and you give them ventilation support. You do not give them any diuretics, nothing at all, because diuretics is just going to make it worse because they're already hypotensive. All right. How do you prevent this? You can give them male-only plasma. Why? You can give them male-only plasma, meaning that the plasma comes from a male donor, because usually multiparous women, they produce more HLA antibodies. So the entire takeaway from this slide, there's HLA antibodies binding to your neutrophils, destroying your pulmonary endothelial lining, causing the lungs to, become incompetent. And basically, the patient is going to be hypotensive, hypoxic, dyspneic, and basically, there's any circulatory overload. So basically, the heart is not involved. This is just translation. And that's it. Now, in TACO, basically, it's a transfusion-associated circulatory overload. Here, what happens is that you have volume overload exceeding your cardiac capacity. Okay, and then you start to have hydrostatic edema in your lungs. So if you can appreciate, there's fluid everywhere. Like the blood is not just in your, not blood, I would say, sorry, fluid. The fluid is not just in your heart, there's also in your lungs. Okay, so this is pulmonary edema. And also if we can appreciate the cardiac silhouette, so cardiomegaly. So usually these patients already probably have pre-existing cardiac condition, or it could just be from the transfusion itself. Now, how do we manage these patients? You give them oxygen and you need to give them diuretic. Like, how can I confirm that they're actually having TACO and they're just not having something else? They're just maybe hemodynamically unstable, or maybe it's a heart failure thingy. You need to check the BMP level. Okay, I'll tell you why. So basically, in your right, the atria, let's say in general, okay, when there's too much blood pressing on the muscle, okay, of the atria, what happens is it triggers it to release BMP. So when you're overloaded, okay, there's a lot of pressure on the walls that's causing BMP to increase. So when you have BNP more than 100 with these symptoms and you're basically transfusing the patient with blood aslan, this is diagnostic of TACOs. Okay. Second thing is the massive transfusion. So massive transfusion basically, this depends طبعا. What do we mean by massive transfusion? We have three definitions. Either you give one blood volume in 24 hours, so you give like 5 liters in 24 hours, that's crazy amount of blood. Or you give 50% of the blood in less than 3 hours, or you give 5 units of RBCs in 3 hours. This is massive transfusion. And we've mentioned before that massive transfusion can cause what? Dilution. Okay, so the patient can have thrombocytopenia. Now, not just that, when basically you're massively pumping blood into someone's vessels, they can become hypothermic. They can also have hyperkalemia because the blood will definitely contain potassium. And they could also have coagulopathy. And this is due to basically how to say it? There's like turbulence in the blood. There's not a certain flow, and this turbulence can trigger, thrombosis. Something that's a very high yield that I want you guys to leave the slide with is citrate toxicity. And how does it show? It basically shows with hypocalcemia. Because usually blood that's being transfused, they do have citrate. And citrate is what? A chelating agent, meaning they're going to bind to calcium. Okay, which is why the patient could have hypocalcemia. And I've seen this question in step 1. Okay, now how do we prevent this? We use blood warmers. So basically you're preventing the complications, and you also give platelets to prevent thrombocytopenia, and you also give fresh frozen plasma if the patient was bleeding, as I mentioned earlier, because you want to increase their coagulating factors. Okay. Lastly, we have the delayed transfusion reaction. So anything that happens after 24 hours. It could be immune-mediated or it could be non-immune mediated. First one is the delayed serological hemolytic transfusion reaction. Now, this one is seen in thalassemia major, sickle cell disease, multiparous women, and repeated transfusion. The idea here is that they're going to have antibodies against minor antigen, KEL, KID, and Duffy. The most common one is KID. Okay, so what's going to happen here, your hemoglobin is going to fail to rise. Okay, so it's not going to rise. So the patient can actually come in and develop mild jaundice, despite the fact that you just literally transfused them. So what do you do here? You want to give the patient an antigen negative blood. So the idea here is about, it's a serological issue. Okay, the antigen serology is not matching. This will cause the blood to just, have immune-mediated hemolysis. So again, antibodies, KID is the most common one. Basically, it's going to cause hemolysis, and your hemoglobin is not going to raise because you're basically losing it in your urine. Okay, so they can also develop mild jaundice due to the indirect bilirubin. Now, we have transfusion-associated graft versus host disease. I think this is maybe the most important one out of all of these. The idea here is that you have the donor lymphocyte, they're attacking the recipient tissue. And the most common ones are your bone, your liver, your skin. Bone, liver, skin. Very, very important. You have to remember these. Now, they clinically will present with fever because of cytokines. That's one. They attack your skin, you're going to have maculopapular rash. They attack your bone marrow, you're going to have pancytopenia. And you're also going to have bone marrow aplasia. Why aplasia? Because they're not producing cells. Sorry. Yeah, they're not producing cells. Yeah, that's correct. High rate of mortality. More than 90% of people die because of transfusion-associated graft versus host disease. طيب. How do you prevent this? You need to irradiate your blood, as I mentioned earlier, because you have to kill these donor lymphocytes, or else you're just going to attack your recipient tissue because they do consider it as foreign, you know? The only treatment is that you need to do a bone marrow transplant to the patient. Now, second thing is post-transfusion purpura. So this is literally simple purpura right here. And basically, you'll develop anti-HPA-1A antibodies against the platelet. You're going to get severe thrombocytopenia in 1 to 24 days after transfusion. Your platelets are going to be really low, less than 20,000. And this could be due to, this could also lead to spontaneous bleeding. Tamam. You treat it with IVIGs only. Give me a minute and I'll be back. All right. Sorry for that. My laptop was dying. Okay. Let me see. Yeah. All right. So the idea here is that you get antibodies against your platelets. They're basically killing your platelets. You will eventually develop severe thrombocytopenia. Your platelets are going to be low, and then patients can bleed to death. So you want to treat them with immunoglobulins, IV, IG. So, iron overload could also happen, okay, because there are, iron in blood. This is usually seen in patients who are chronically transfused. So thalassemia major, you treat with iron chelation agents like deferoxamine. Yeah. Then you have stem cell transplant. This is the end of the presentation, inshallah. Very short, very quick, very easy. So when we say stem cell transplant, we're basically talking about what? It's not just putting stem cells into the patient body. It's an entire process of eliminating whatever patient had hematopoietically, all right? And then you want to pump the patient immune system on chemotherapy and body irradiation. You want to clear them out. And then you give them hematopoietic stem cells. And imagine you have a plate that's dirty. You want to clean the plate thoroughly, and then you want to make sure it's clean, crystal clear, so that then you can put fresh food into it. Okay. The idea we do this, probably we have messed up bone marrow, defective. Okay. We usually have, malignancies, so we can use high dose chemotherapy. And, when you do this, you definitely want to give stem cell later on because the patient is going to be pancytopenic. And sometimes it's the only curative option for many marrow failure and genetic diseases. So where do we get our sources from? We get them from either bone marrow itself, we get the stem cell from it, or we can get it from the peripheral blood stem cells, most common way, by the way, or we can get it from the umbilical cord. Now, the umbilical cord one is usually collected after delivery and doesn't actually belong to the mother, it doesn't belong to the fetus. Okay, there's a lot of ethical sensitivity around it. However, we use it to save a soul. Okay, so the PBSC is the most commonly stem cell harvest, I would say. Basically, what we do, we give the patient GCSF. Why? GCSF is basically going to increase the hematopoietic stem cells in the blood. Okay, we give it to them for 4 to 5 days, and then we take the blood, and then we try to mobilize the hematopoietic stem cells. Then we connect it to the apheresis machine, and then we get what we want, and we return everything to the blood. The machine needs to collect what? CD34 plus cells. And this is important to know for your SAQs, for your OSPE, and for your MCQ. High yield. And basically, this is your goal yield. I don't think this is important, but I just put it there because Dr. Rehan discussed it. Okay, so this is actually the apheresis machine, and as you can see that, these stem cells are being collected into a bag with citrate, phosphate, dextrose, adenine, CBDA1 for short. The idea is this bag has to have this component to prevent blood clot. طيب. So it's this is your stem cells, this is the plasma going back to the donor. Okay, so second way is we can harvest it from the bone marrow directly. Now, this is the patient needs to go to the OR, they need to be under general anesthesia, and you need to have two hematologists inserting the needles into the iliac crest and getting the bone marrow aspirate. طيب, you need to collect around 500 to 1,200 milliliter marrow in 5 to 10 minutes, and that's how you get your stem cells from there. Cord blood, again, collected at birth. This is the perfect blood because it doesn't have any strict HLA matching needed. However, it's very, very low in cell count, and it's usually suitable for children who are weight less than 55 kilograms. And it does have ethical concerns, which is why we stick to peripheral blood smear, because it's the less invasive and the safest way, to go with. Now, this is extremely important. You have to know your definition. So when I say my donor is an HLA matching sibling, it is an allogenic type. When I say it's from an unrelated HLA matching donor, it's allogenic. So allogenic is basically coming from someone else, okay, not from my body. طيب. Even if it's from the umbilical cord blood, it's still considered allogenic. However, if we're getting it from my own blood, if I'm getting the stem cells from my own blood, it's considered autologous. If I'm getting it from an identical twin, it's considered syngenic. Okay, very important, very easy marks you could lose if you don't know your terminology pretty well. Now, when do I pick what? So I would go with allogenic if I have all of these bunch of diseases that you can go through. I would do autologous if we have multiple myeloma, Hodgkin, or non-Hodgkin lymphoma. طيب? Okay. Now, even in your best centers, you can still have 20 to 30% mortality rate due to infection and toxicity from allogenic hematopoietic stem cell transplant. طيب? So you need to keep that in mind, that there's always a mortality rate due to infections and toxicity. طيب. How do we do this? How do we transplant the patient? So first of all, we need to diagnose the patient with an initial diagnosis. So let's say they have Hodgkin lymphoma, for example. Okay, I want to treat it as Hodgkin lymphoma, first of all. And then if I want to decide to perform stem cell therapy, I'll take that decision, and then I need to identify the donor. So let's say it was autologous from cell. So then I need to, for example, decide where do I need to get it from? Blood smear, bone marrow, and then I need to condition the recipient. I want to prepare my patient to receive new blood. And we do that with high-dose chemotherapy and total body irradiation. And then I infuse my patient with stem cells. First day, I give it an IV. And then day 1 to day 21, this is the most sensitive and critical phase because the patient is going to be pancytopenic. You wiped out his entire bloodline, okay, of all platelets, WBCs, and you're basically giving him something new. So here is when then the patient will start having infections, most commonly bacterial, fungal, and viral, bleeding, mucositis, okay, organ toxicity as well. And then we need to support the patient until engraftment occur. What is engraftment? Engraftment means when I see that there's neutrophils in my blood, okay? When I see there's monocyte and neutrophils in my blood, this is engraftment, and I can feel that, okay, my transplant did work. طبعا the golden number is 1,500 of absolute neutrophilic count. 1,500, very important number, very, very high yield, okay? Because this indicates that the patient engraftment worked, and he's basically in their engraftment period. Now, you have to daily monitor their CBC, okay? Because, for example, if their hemoglobin was low, you need to give them RBCs. If their platelet was low, you need to give them platelets, okay? And engraftment طبعا happens at 2 to 3 weeks, not something instant. And it's the fastest in peripheral blood smear. طيب, let's say that the patient developed hemoglobin A2 with more than 3.5%. This is diagnostic for thalassemia minor. And you need to remember this number specifically. If the hemoglobin A2 is more than 3.5, this is diagnostic for thalassemia minor. Okay. Complications, طبعا there are so many complications, and I already mentioned them. Number one is infection. طيب, bacterial, fungal, viral. The patient could bleed. Imagine pancytopenia. Okay, if you lose neutrophils, you can have infections. If you lose your your platelets, you can bleed to death. طيب, you can have organ toxicity. You can have hemorrhagic cystitis. You can have infertility. Okay, you can also even develop cataracts from the radiation. So all of these are complications. And I think this is towards the end. So these are the very most common pathogens that usually pop up as post-transplant infection: Candida, Aspergillus, CMV, high yield, and you want to know that you give them acyclovir or ganciclovir, and you also have EBV. طيب. Now, coming back to this very, very important disease, because as we mentioned earlier, they have very high mortality rate. The graft versus host disease. So this is basically when as we mentioned, the donor T cells, the donor lymphocytes are just active and they're attacking the recipient tissue. Now, sometimes this is good. Why? Because if the patient, for example, is having acute lymphoid leukemia, they're attacking the leukemia. This is good. But it's bad if they're attacking, normal tissues, like your skin, like your bone, like your liver. So we need to find the balance in that immunosuppression. As I mentioned again, these are the things that they usually target. So you're conditioning the patient and then suddenly the patient that will develop tissue damage in skin, liver, and GI tract. And we have two types. We have the acute and we have the chronic. Acute will happen within the first 100 days. And as I mentioned, they're going to have maculopapular rash, high bilirubin, high LP, and then they're going to have GI symptoms. We treat with high dose steroids in this scenario. However, if the patient is coming in with these, skin, liver, bone, but more advanced, like scleroderma, skin tightening, joint stiffness, Sjogren-like symptoms, after 100 days, you treat them with immunosuppression. And you want to know if the blood is coming from an identical twin. If it was syngenic, there's no way that a patient is going to develop graft versus host disease, and it's probably safe. So you don't want to think of that if it's going to be to an identical twin. And with that, I conclude my lecture. Thank you so much for bearing with me, and I hope that your exam goes well. And I'm sure that if you focus on the clinically important things, you're going to ace your exam, inshallah. If you have any questions, please feel free to reach out to me. Inshallah, I'll be of help. And good luck on your exams. Have a good day.